Well, good morning, everyone, and a very warm welcome back for our fall season of Grand Rounds. We are currently still available only virtually for Grand Rounds, but please do stay tuned as we hope to bring back at least limited live viewership one of these weeks. We're here on the team's live platform, which has also been a great opportunity to expand our viewership. You can earn CME credit by watching here with us live virtual, or also by watching a recording of the session. And the link to that recording is available through the invite for this live session. We'll send a follow-up email after today's Grand Rounds as well. I'll be monitoring the Q&A throughout the session today, so please do go ahead and post your comments and questions. I will mostly hold them for the end to ask our guest as time permits. And it is a particular delight to kick off our fall season with the 2021 Huldrych-Kammer Memorial Lectureship. For those of you who do not know, Dr. Huldrych-Kammer touched countless lives as a role model physician, a pioneering endocrinologist, a gifted teacher, and a true lifelong learner. One of the first full-time doctors of endocrinology in Oregon, Dr. Kammer was soon considered the city's leading endocrinologist. He also served as Associate Director of the Internal Medicine Residency at Providence Portland Medical Center for over 30 years, and also as Professor of Medicine at Oregon Health and Science University. Over the decades, Dr. Kammer trained hundreds of students, residents, and fellows who benefited not only from his love of teaching, but his passion for lifelong personal scholarship. He was also admired as a mentor to fellow physicians, and he published seminal work and contributed greatly to the modern era of endocrinology. And it is in his honor that I am really happy to have the privilege of introducing today's speaker, and that is Dr. Dolores Shobak. She is Professor of Medicine at University of California, San Francisco, and also staff endocrinologist at the San Francisco VA. In addition, serves as Associate Director of the Diabetes Endocrinology and Metabolism Fellowship Training Program at UCSF. Dr. Shobak earned her medical degree and completed residency at Johns Hopkins before doing fellowship training in endocrinology at Harvard. Dr. Shobak joined University of California, San Francisco in 1985, where her clinical interests focus on metabolic bone diseases, parathyroid disorders, and osteoporosis, though she maintains an active clinical practice, including attending on the general medical service at the VA. Dr. Shobak is also very much engaged in research, focusing on aspects including mechanisms underlying the regulation of parathyroid hormone, as well as its use in the treatment of osteoporosis and hypoparathyroidism. She has co-authored over 130 papers, reviews, and editorials. And Dr. Shobak has held many leadership positions, including current Secretary-Treasurer of the Endocrine Society, and has participated in guideline development, including the management of primary hyperparathyroidism, as well as the pharmacologic treatment of postmenopausal osteoporosis. As you can imagine, we are absolutely delighted to have her with us today to share her expertise and her passion for teaching. Thank you so much, Dr. Shobak. And I'm happy to turn it over to you.
Thank you very much, Dr. Locher. Can you see my slides okay?
Looks perfect, thank you.
Okay. It is really an incredible privilege for me to speak in honor of the memory of Dr. Kammer. And really judging from what I've read about him and what you've said, it's clear that he was really a beloved and dedicated, almost larger than life clinician and teacher here at your medical center, and active up until really the day literally that he passed away. So really an inspiration to all of us. My topic is going to be optimizing osteoporosis therapy. This is just a picture, and I will make one comment. And Dr. McClung had sent me some remarks about Dr. Kammer, and he described him as the consummate clinician and clinical endocrinologist, learning about classic disease long before hormone assays became available, and recognizing disease on the basis of history and exam. That was later confirmed by lab testing. So really the consummate clinician. And I can't help but comment on his service of over 30 years as Associate Director of Internal Medicine. In this age of instantaneous burnout, it seems incredible that someone could do that job for over 30 years. So it's a real privilege to honor his memory. I have no disclosures or conflicts with regard to this lecture. And so, as I said, my focus here is to talk about optimizing osteoporosis therapy. And it really focuses on several sort of key concepts. The first really is sort of the judicious use of medications, the older medications that we know a lot about, and now the newer medications, and using them in logical and effective sequences of therapy for our patients. I'm going to touch very briefly on two sets of guidelines that are very current. The one from the Endocrine Society, and you can see it was published 2 years ago. And then the other from the American Association of Clinical Endocrinologists. Sort of themes that come out of those guidelines are risk stratification of patients, how important that is in our approach to therapy, and then really aligning our decisions on therapy to that individual's fracture risk. I want to touch on a concept which is gaining a lot of traction in the field, sort of called imminent fracture risk, and then turn in the final part to sort of exciting trial data on some sequential regimens for therapy with the anabolics, and both Abaloparatide and Romosozumab are the new ones in that regard. And what I'll try to do is sort of focus on the best therapy sequences to maximize anti-fracture benefits. So I want to frame this discussion in terms of a patient whom I saw a few years back and whom I still continue to see. When I met her, she was a 57-year-old woman who'd come from the hospitalist service at UCSF after an admission for severe back pain due to a fracture. As she told her story while she was walking to work, she's a nurse practitioner in one of our clinics, she leaned forward maybe about 5 degrees and heard this loud pop coming, she thinks, from her back, and that was followed instantly by severe back pain at the waist level, 10 out of 10, sharp, radiating down both of her legs to her feet. She went on to work, but 2 days later, she presented to the screening clinic for pain and muscle spasms. She was given some cyclobenzaprine with some relief. At that time, she had no motor or sensory complaints or incontinence. 3 days later from that, because she was unable to work due to the pain, she presented to the emergency room, and x-rays were done confirming a compression fracture of L1, and she was admitted for pain control and further evaluation. And so you can see her CT scan here on the left and her MRI on the right. And I think you can appreciate she's got about a 40 to 50% compression of L1 with a retropulsed superior end plate fragment of bone here in the spinal canal. When we look at the T2 weighted fat suppressed MRI, the radiologists tell me that the intensity of this signal on these sequences tell you that this is an acute fracture. When they looked on the scout films, they saw no other lesions, no lytic blastic lesions specifically. They felt the cord signal was normal. There was no cord compression. There was no epidural hematoma. But they also noted a 40% T7 compression fracture, which you can't see on these images. So here we have this 57-year-old woman. She'd been healthy the rest of her life. She'd never used any steroids. She had menopause at a normal age, 50 to 51 or so. She did have some rib fractures at the age of 53. She fell over a coffee table in her living room, and another after being tightly hugged. With that in mind, her internist did a DEXA scan, which diagnosed osteoporosis, and she was started on weekly Alendronate, which she took faithfully, along with calcium and vitamin D supplements for the ensuing 4 years up until the time that she presented to the emergency room. Her exam was completely normal. nothing except severe back pain. And I did a very thorough lab workup for secondary causes, and nothing was revealed. And she had negative cancer screening testing in an ongoing way. Well, here was her bone density by DEXA at the age of 53 when she had those rib fractures, and you can see she was markedly osteoporotic at the L spine. She was also osteoporotic by T-scores at the femoral neck and moderately osteopenic at the total hip. 4 years later, after 4 years of Alendronate, and when I saw her in the office, her L spine was still negative 3.3, her femoral neck negative 2.4, and you can see the total hip. So when I did the arithmetic, she'd had a 5% improvement at the spine and almost a 6% at the femoral neck. So in fact, she had technically responded to bisphosphonate therapy. But I want you to think about her as we go through this lecture and what you might do in terms of treating her. I'd like to start first with just a very high-level view of this clinical practice guideline that I had the opportunity to work on for the Endocrine Society to go over drug management of osteoporosis in postmenopausal women. This was a big effort. The guideline is based on 2 large systematic reviews that synthesized data from over 100 trials. It included data on nearly 200,000 postmenopausal women in these trials, mean age 66, the majority white, and the average duration of the trial is sort of 2 to 4 years. Now, the meta-analyses that were used, that were incorporated on these data were twofold. One was a direct comparison with placebo, and then the other was a combination of direct and indirect comparisons, or what's called a network approach. This was considered, is considered a very state-of-the-art technique for meta-analyses. And then finally, the grade system out of McMaster University was used to calibrate each of the recommendations in this guideline. Now, the algorithm, I'll show you it in a moment, is based on 4 important kind of management principles, and I think we use these every day in practice, but just to make it very clear, we start with a determination of the risk of future fractures in the patient that we have in front of us, and you use whatever is the correct appropriate country-specific assessment tool, and for the US, it's generally the FRAX algorithm. Of course, we incorporate patient preferences into any treatment regimen we're going to pick. And then we recommend nutritional and lifestyle interventions and fall preventions really as part of any regimen that we're going to use. And then finally, I think it's critically important to appreciate that there are multiple pharmacologic therapies that we now have that reduce fracture rates in women at high risk, and the safety and risk-benefit profiles are certainly acceptable. So what did this guideline put forward as a way to risk stratify? Well, we start with bone density by DEXA and then calculate 10-year fracture risks by FRAX. And this guideline defined 4 risk categories, sort of the low risk woman, the moderate risk, the high risk, and the very high risk. And so that low risk woman has no fractures, good BMD, and FRAX scores are all within an acceptable range. The moderate risk woman has no fractures, but she's got a T-score between -1 and -2.5, but her FRAX scores, again, don't put her in a range where you might trigger therapy. And then the high-risk patient is one who's got a prior spine or hip fracture, has T-scores below -2.5, and then does meet the criteria through FRAX for considering therapy, either at the hip or the 10-year major osteoporotic fracture risk. And then the very high risk is multiple fractures with T-scores below -2.5. So just a way to kind of think about how to risk stratify our patients. Now, those meta-analyses that were done kind of are summarized on this one slide. And what we are looking at here are all the therapies on the left, on the y-axis, that we have for osteoporosis really in the world. And then the dotted line is the relative risk of 1, and anything to the left, as you know, particularly if it doesn't touch that dotted line, is statistically significant and capable compared to placebo of reducing fracture risk. And so I think you can appreciate, without my reading all these names of the medications, that most of the medications that we have approved for treatment of osteoporosis in the US statistically significantly reduce the risk compared to placebo of vertebral fractures. Now, when we move to the middle here for the non-vertebral fractures, fewer agents do that, but there are quite a few that do. Hormone therapy does, teriparatide, denosumab, Residronate, and Alendronate, and so forth, and Abaloparatide, which I missed over here. And then finally, sort of the toughest bar, the hip fracture. You can see that there are several therapies in our armamentarium. Hormone therapy, in fact, zoledronic acid, Residronate, Alendronate, and denosumab, all of them capable of reducing the risk of hip fracture compared to placebo. So this is kind of the bedrock, if you will, upon which this guideline is based. Now, what I've shown you here is the algorithm that's published in that Endocrine Society guideline, and it starts with nutritional and lifestyle optimization for all postmenopausal women, determining the 10-year fracture risk, and then categorizing kind of as low to moderate risk over here on your left and high to very high risk over here on your right. And just to take a moment, the low to moderate risk patient is one that you're probably going to monitor over time every 2 to 4 years with a reassessment of fracture risk, and potentially moving over into this category, but potentially also staying over here. In the high to very high risk, all of these therapies that are boxed in blue are certainly candidate therapies for these patients. And then with that therapy comes each of the downstream effects. For example, a patient who is at high risk that you're going to treat for osteoporosis with bisphosphonates, she might be treated for 3 to 5 years with an oral drug, and then if she becomes low to moderate risk, go on a drug holiday with fracture risk assessment periodically. If she becomes high risk or loses bone, she may go back onto therapy and so forth. If she's high risk at the end of that, you may continue therapy for another 5 years, potentially, with bisphosphonate, or switch to another therapy. And then these anabolic therapies, which I'll have more to say about, do have kind of a very specialized plan after their initial either 2 years of therapy for teriparatide or abaloparatide, or 1 year of therapy for romosozumab. And denosumab is over here. 5 to 10 years of therapy is the typical course. Now, there are certainly patients who are intolerant or inappropriate for these therapies, and in those individuals, depending on age, for example, and other risk factors, you may use a SERM, for example, you may use hormone therapy, or could even consider some of the drugs or in this category, like a SERM or calcitonin and so forth. So kind of a one-stop way to kind of think about management of postmenopausal osteoporosis. Just 2 very quick slides on highlights of the management recommendations overall. And I think the first one is probably the most important, which is a strong recommendation. When you use the word recommend, it means the data are strong, so level 1 evidence with 4 pluses behind it. And that recommendation is to treat women at high risk of fracture, especially those who've had a recent fracture, with the pharmacologic therapies I've already outlined, because benefits outweigh risks. With the bisphosphonates, again, level 1 evidence and multiple pluses here because the data base is strong. It's an excellent agent as initial therapy, and really all 4 of these agents reduce fracture risk. Risk assessment is made after 3 to 5 years, and then over time during a holiday, for example, if there's a decline, one can reinstitute therapy. Denosumab is another excellent agent in patients at high risk for fracture. You can see level 1 evidence and 4 pluses because the database on which that statement is made is strong. We don't give a drug holiday with denosumab because there's the potential for rebound fractures and rebound increases in bone turnover. And therapy can be continued. And this is only at the level of suggest for 5 to 10 years and then risk reassessed. In terms of the anabolic agents, and I'll have more to say about them, these are recommended for women at very high risk of fracture, given for up to 2 years, and you can see strong evidence base, level 1 and 3 pluses. And then in addition, after a 2-year course of these therapies, it's recommended that anti-resorptive therapies be instituted to maintain the gains that occurred. And finally, Romosozumab, I'll have more to say about it. Again, recommended for women at very high risk of fracture for treatment of up to 1 year, high level of trial data, level 1 and 3 pluses. And I'll talk a little bit more about cardiovascular disease in that discussion. And then after a course, treatment with an anti-resorptive. And we don't have time to go into it, but this guideline also includes recommendations with regard to these medications I've listed here. In addition, last year, the American Association of Clinical Endocrinologists came out with their guideline for diagnosis and treatment of osteoporosis, again, based on reviewing clinical evidence and a grading by the task force of experts, and I'll point out to you that Dr. Michael McClung was among those experts who co-authored these guidelines. A similar evidence grading system used. They made 52 recommendations, so a very detailed, comprehensive review, and answered 12 key questions. And we won't be able to go into those, but just know that this is a very superb document as well. This is their algorithm, and it's very similar to the one I already presented to you. Risk assessment by DEXA, fracture history, FRAX calculation, evaluation for secondary causes of osteoporosis, correction of vitamin D deficiency, and then pharmacologic therapy along with lifestyle measures. And they categorized patients into two very straightforward risk categories: the high-risk woman with no prior fractures, and then the very high-risk woman with prior fractures. And over here on your left, in the sort of green, the high risk but no prior fractures, one might start with a bisphosphonate, denosumab, and then alternative therapy would be raloxifene or abandronate, reassessment on a regular basis, and if the patient is doing well, consider a drug holiday after a period of treatment, and if the patient progresses, what you can do to assess compliance, for example, and then switching either to a parenteral therapy or something over here on this side, the anabolic agents that are out there. In the very high risk group, consider a stronger initial therapy, potentially with abaloparatide, denosumab, romosozumab, teriparatide, and these are in alphabetical order. There's no hierarchy here, or at least it seemed to me that this was alphabetical order. And alternative therapies, of course, would be the bisphosphonates. And then yearly for the response to therapy. And then with each agent, one needs to think a little bit differently about how one treats downstream. But I think this is a very nice algorithm for working your way through different treatment regimens that you might select for that individual. So I think one of their particular key questions I wanted to focus on in this particular slide, and that is who needs treatment? And this is their recommendation 23. They grade that evidence as B. And the answer to that question really was, consider these groups to be at very high fracture risk. And I think this is concrete and very practical. So those patients who've had recent fractures within 12 months, that's a very high fracture risk group. Patients with fractures on approved therapies, again, marks you as someone who needs perhaps special attention. Someone with multiple fractures, patients who fracture on medications that we know are bad for bone, for example, glucocorticoids, patients at very high risk for falls, and patients with a history of injurious falls. And I make a little footnote here because I'm seeing more and more patients with Parkinson's disease who have, significant gait problems, or patients with dementia who fall and have very significant skeletal and musculoskeletal injuries from those falls. Patients with very low T-scores, and they chose a number less than -3. And then for FRAX scores, those that are over 30% for the 10-year risk of a major fracture and over 4.5% for the 10-year risk of hip fractures. And I like these criteria because they put a little bit more detail, a little bit more granularity to how we might assess our patients. So I wanted to talk a little bit about sort of two concepts of fracture risk, and I think these are gaining more and more traction as we move forward, as this field becomes more nuanced and sophisticated. And sort of one concept of fracture risk is the sort of the baseline risk that the patient presents to you. The patient characteristics, the age, the time of menopause, things like that. The DEXA that patient has, and the FRAX scores that patient presents. Okay, but then the other concept of fracture risk is what's been termed the imminent or near-term fracture risk. And I think it's critical to really assess patients from both standpoints because they both tell us something that's highly informative. So what's this imminent near-term fracture risk? And that really refers to what that patient might be expected to experience over the next 1 to 2 years. So where does this concept come from? Well, about 20 years ago, Dr. Lindsay and his colleagues wrote a paper looking at women who'd had radiographic vertebral fractures that occurred in the prior year, known to occur in the prior year. And what they found was that the absolute risk for an incident fracture in the next year, in just the next 12 months, was 20% for those women who'd had a vertebral fracture, radiographic vertebral fracture in the prior year. This study from 2012 looked at patients with multiple fractures, even if they were remote. And it was 50,000 women, you can see over the age of 55. And when they looked at the 2-year incidence of fracture in those women, okay, if you had no prior fracture, your rate in the next 2 years was 5%. If you had one prior fracture, it was 10%. And you can see it goes up with the number. And if you had 3 or more fractures, the risk of a fracture in the next 2 years was 25%, incredibly high. Okay, and then finally, this last study to just share with you is one that came out in 2019, looking at women, almost 400,000 of them on Medicare, who'd had an incident fracture, non-traumatic, and they looked at the rate of fractures in the ensuing 5 years. And just to summarize, if you'd had a fracture as a Medicare claims patient, you had a 10% risk of having another clinical fracture in the next year, 18% in the next 2 years, and 30% risk of a fracture over the next 5 years. So fractures beget fractures. These are their 2-year data of imminent fracture risk by the age of the patient and the site of the initial fracture. And I think this is one of the most telling things right here. If you are a woman who has a spine fracture, it really doesn't matter what your age is. Over the next 2 years, you've got a 25% chance of having a subsequent fracture. So very high imminent fracture risk. And you can see the other fracture sites are shown here. These are the 5-year data from that study, and this is the time to a subsequent fracture in those that had 5 years of follow-up. And again, this pink line is the vertebral fracture. And so over a 5-year follow-up period, if you have a vertebral fracture at the outset of joining this cohort, you've got about a 40% chance of having another fracture, osteoporotic fracture, over the next 5 years. Hip fractures about 25%, and pelvic fractures, I think, which don't receive a lot of clinical attention, really are up there near 30%. So harbingers of future fractures if that patient has a fracture when you are seeing them. So the high near-term fracture risk patient should probably be receiving more aggressive therapy than we're currently giving. And I would suggest to you that maybe the initial therapy should be with an anabolic agent for that particular kind of patient. And this concept is emerging, not yet folded into guidelines, but definitely emerging. So I'd like to turn in this last portion of my talk to the anabolic agents that we have for osteoporosis treatment. And these are these data, I think, and these trials are very exciting because these agents have the potential to kind of repair the micro damage. This is osteoporotic bone, and you can see micro fractures and micro cracks here. And anabolic agents have the potential to fix that microarchitecture. And that's why I think many of us who work in this area are so excited about them. So you know we have teriparatide, recombinant PTH 1-34. It's been in the clinic for 20 years. We know it's effective at preventing spine and non-vertebral fractures. What's new in this area? Well, we don't have too many new trials, but we do have some good and important safety information, and that's that the FDA removed the black box warning on the label of teriparatide, the black box warning related to the osteosarcomas in rats. They also removed the treatment limitation, which was previously 2 years of therapy. That's been removed, and you can now consider a repeat course of therapy if the patient remains at or returns to being at high risk for fracture. So that's really the update regarding teriparatide. Lots of clinical experience with its use. And there are two other agents, though, that have been more recently approved and are gaining traction in the clinic. And one of those is abaloparatide. It's been out for about 5 years. And the other is Romosozumab, which we've got just about 2 years of experience with. And with these agents, and I think the trial data will nicely support it, the sequence of therapy and getting it right with respect to that sequence is incredibly important. So what's abaloparatide? I know most of you are internists and individuals in practice and in training. This is an analog, a sort of designer analog, if you will, of the human PTH-related peptide 1-34. And the sequences for 3 of these peptides schematically are shown here. And in blue lettering is abaloparatide. And I think you can appreciate it's got 100% identity with PTH-related protein in the first 21 amino acids. And then the sort of C-terminal portion of this peptide in the blue areas diverges from PTH-related protein. So it's very similar to the PTH-related protein. It was designed on the basis of that sequence with the idea that you would get anabolic action of this peptide because PTH and PTH-RP are both anabolic. But by making these critical substitutions, you might dissociate the effects of PTH to stimulate bone resorption. Okay, so we call this a biased agonist of the receptor. It's biased in its actions downstream. It stimulates formation without resorption. So let's see how it behaves in clinical care. So this is just the structure of the phase 3 trial that established the efficacy of abaloparatide, and the trial was called ACTIVE. And you can see it head-to-head compared abaloparatide here at 80 micrograms by daily injection with placebo and with teriparatide. Okay, and then that was an 18-month trial. And then in the extension, all of these patients in the 2 upper arms went on to Alendronate weekly therapy. So that's the structure of the trial. So this is a summary. It's a busy slide, but it's a summary of the several of the fracture outcomes from this active trial. And just remember, it only took 18 months to get these effects. So if we start with morphometric new vertebral fractures, there was an 86% reduction in those new fractures compared to placebo. And that was the primary endpoint of the study. So it met its primary endpoint, highly statistically significant. When we look at non-vertebral fractures up here in the left in panel A, and abaloparatide is this orange line here compared to placebo and teriparatide, they got a 43% decrease in non-vertebral fractures versus placebo, also statistically significant. When they looked at all clinical fractures, also a 43% decrease with 18 months of abaloparatide therapy. And then finally, in panel C, the major osteoporotic fractures, the 4 fractures that are included in the FRAX algorithm when we counted up, there was a 70%, you can see this orange line here, 70% decrease in major osteoporotic fractures over 18 months of therapy. And this actually did outperform teriparatide in that clinical trial. So it's a new peptide in the clinic. What did it do in terms of adverse events? What do we need to be on the lookout for? Dizziness was one of them, joint aches, back pain, nausea. Those were the most common, but they were balanced. There was some hypercalciuria in these patients. You can see about 10%. Serious adverse events were balanced. You can see the rate of those across the 3 groups. Discontinuations, a little bit more with the abaloparatide. Maybe some of these side effects led there compared to the others. And the overall incidence of hypercalcemia was actually less with the abaloparatide compared to teriparatide, suggesting that they actually had dissociated the stimulation of resorption and the stimulation of formation of these peptides. So those were the adverse events they saw. Now, when the study got extended, when patients on placebo or abaloparatide went on to Alendronate for up to 4 years, the data for vertebral fractures is shown here, and I've circled what went on during that extension period. So during the extension, patients who had been on abaloparatide followed by Alendronate had an 87% relative risk reduction compared to those just on almost 2 years of Alendronate therapy. So that benefit is maintained even compared to patients on active therapy. And if you look at the entire active study along with its extension, the relative risk reduction for vertebral fractures was very strongly significant at 84% relative risk reduction. When they looked at the other fractures captured in the extension trial, patients who had received abaloparatide followed by Alendronate compared to the placebo followed by Alendronate, there was a nearly 40% reduction in non-vertebral fractures, nearly a 34% reduction in all clinical fractures compared to this gray line here for the placebo and Alendronate. And then again, the major osteoporotic fractures captured by FRAX were reduced by approximately 50% in patients who'd had a course, an 18-month course of abaloparatide. So just hammering home the fact that the treatment sequence matters tremendously here, and the carryover of benefits from a course of anabolic therapy really can be seen years later. And I think that's a very important message. So the final pathway to talk to you about is really a brand new one that we're targeting now in osteoporosis therapy, and that's the Wnt pathway. And it's diagrammed schematically here in panel A. Wnt is the ligand, and it interacts with its receptor and co-receptor, frizzled and LRP5. It stimulates sort of a cascade of signaling that if you're an osteoblast, leads to new bone getting formed and bone resorption getting blocked. So you've got a dual effect of Wnt stimulation, and this is very important. Now, sclerostin is this little red circular molecule here, and its normal job, and it's made in the osteocytes, which are the key cells of bone. Sclerostin is a natural inhibitor of the Wnt pathway. So when it gets into the bone microenvironment, it blocks the interaction between Wnt and its receptor, and downstream events, the pathway gets turned off and no new bone is formed. So if you develop a potent neutralizing antibody, Romosozumab is its name, to neutralize this sclerostin molecule, you get sort of unmitigated, if you will, Wnt signaling. You get an increase in new bone formation on quiescent surfaces, and you get a decrease in bone resorption. So very potent and dual actions taking place with this particular intervention. 2 trials to quickly review with you. The first is FRAME, called FRAME. It was 7,000 postmenopausal women who were randomized to either placebo injections once a month or Romosozumab injections monthly for 12 months. And then everyone went into an open label extension with denosumab, the rank ligand monoclonal antibody, and then into an extension study. So that's the structure of the FRAME study. What occurred with bone density in these patients? So if we look first at the lumbar spine, and the upper curve are the women who received Romosozumab followed by denosumab. You can see that after 12 months of Romosozumab, these women had approximately 13% increases in spine bone density, and it went up to almost 18% at the end of 24 months. At the total hip in panel B, you can see the changes were 9% at the total hip and 7% at the femoral neck, really striking and very significant increases in BMD with just 12 months and then follow on 24 months of therapy in this sequence, Romosozumab to denosumab, compared to patients on placebo versus 12 months of denosumab. What did this do in terms of fracture? Well, in the upper panels, you can see the new vertebral fracture data are captured. And for the first 12 months, when Romosozumab in gold was compared to placebo, there was a 73% reduction in new vertebral fractures in these women. And if you looked over the first 24 months over here, those who in green, those who received Romosozumab followed by denosumab, compared to just 12 months of denosumab here in purple, you can see there was a 75% relative risk reduction in new vertebral fractures. So very significant fracture reduction for the vertebral fractures. In these two panels below, there's the time to event analysis done for the first clinical fracture, and it's in red for the patients who got Romosozumab. And you can see these curves separate well before 12 months, and they stay separated. So it takes longer to have a clinical fracture if you've received a course of Romosozumab, and it takes longer to have a non-vertebral fracture in the same time to event analysis, almost making statistical significance, but nonetheless an impressive separation of these curves. When they looked again long-term now at 36 months for all clinical fractures, there's almost a 30% reduction in those who received a course of Romosozumab versus just denosumab and placebo in the early part of the trial, and similarly non-vertebral fractures still reduced by an additional 20%. So I think the long-term benefit from 1 year of anabolic therapy is very clear, even years into therapy. One other trial to briefly review with you was called ARCH, and this actually was a superiority trial where Romosozumab was compared to Alendronate in the double-blind period, and then everyone went into open label Alendronate. I'll point out to you that this was a very high risk, an older population. Everyone had to have a fracture at baseline to get into this study. Similar BMD responses to what I've shown you from the FRAME study, 14% at the spine at 12 months, 15% over here at 36 months, and similarly at the hip, 6% at 12 months, 7% at 24 and 36 months. And when you look at the Alendronate, and so these are the women that received Alendronate all the way through for both the spine and the hip, you can see the responses in terms of BMD are about 50 to 60% of the responses that you see with Romosozumab followed by Alendronate. And that's a very important point, and I think helps to explain the fracture data, which are shown here. So again, the incidence of new vertebral fractures over the first 12 months of that study, direct comparison, 37% difference favoring Romosozumab over Alendronate. And over the first 24 months, almost a 50% relative risk reduction for new vertebral fractures with this course of Romosozumab compared to Alendronate. Same time to first clinical fracture. It takes longer to have one of those if you've received a course of Romosozumab, and similarly for the time to first non-vertebral fractures, it's taking longer to get there if you had a course of Romosozumab. And finally, I think one of the most important outcomes of this study was a reduction in hip fractures. And those patients who received a course of Romosozumab followed by Alendronate had about a 38% reduction in having a hip fracture compared to those on active treatment with Alendronate for 3 years, and this was also statistically significant. So this agent is superior to Alendronate in fracture reduction, and these are the data that support that claim. What about adverse events? These are the ones from the FRAME study, that first one I presented to you. They were balanced in terms of both regular adverse events and then serious adverse events over 24 months. There were more injection site reactions with this monoclonal antibody compared to placebo. And the serious adverse events that were cardiovascular were also balanced across the 24 months, including death. Now, they looked very carefully at osteonecrosis of the jaw and atypical femur fractures because, if you recall, this agent also has an effect to inhibit bone resorption. So it does have anti-resorptive properties. And there were only 1 or 2 of these throughout the whole study, so no signal for those side effects. Now, what about the ARCH study? This is the table taken from the New England Journal of Medicine paper. You can see adverse events were balanced overall. Serious adverse events were also balanced. But when it came to adjudicated serious cardiovascular events, there was about a 30% difference in Romosozumab group versus placebo. When they looked at cardiac ischemic events, that was about 2.5-fold difference, you can see, but the number of events was really small, 6 in the Alendronate group, 16 over here. The odds ratio of a cerebrovascular event was about 2.2 fold increase. You can see the number of events is also small here, and you can see the number of deaths. So the FDA spent a lot of time thinking about and adjudicating all of these events very carefully, and they decided to approve the drug but put a black box warning on it about the possibility of increasing the risk of MI, stroke, and death. You've seen the actual numbers. And they recommend that treatment not be initiated in patients who've had an MI or stroke within the preceding year, and if one of those events occurs, to discontinue therapy. So that's the nature of the label at this point in time. So we've kind of come full circle here, and I want to come back to this algorithm and sort of pose the question, who are the candidates that we see in the clinic now who might be good for anabolic therapies? And I would suggest to you that there are actually a fair number of high-risk categories as we go through treating our patients. Either they may start as high risk to very high risk, or may have minimal response to bisphosphonates or fracture and become high risk over here. Or after therapy, for example, with denosumab, they may still be a high risk for fracture, and you may come back to considering an anabolic therapy in those patients. So I think it's probably a larger number of patients than you might think about that you have in your clinic, probably more than all of us anticipate. So let's come back to that 57-year-old woman with the history of rib fractures that I presented to you at the beginning of the talk, low BMD, religious therapy with Alendronate for 4 years, but hospitalized with a painful L1 fracture and also found to have a T7 fracture, who I would suggest to you is at high risk for imminent fracture. These are the data on her bone density over time. Here she was when I saw her 5 years ago. These were her bone densities. We initiated, because that was the agent that we really only had at that time, teriparatide therapy for 2 years, and you can see the bone density changes that she experienced. She then went on to denosumab as a consolidation and follow-on therapy, and you can see the bone density improvements at the spine that she experienced, 21% overall, about 6% at the femoral neck, and a very modest 4% at the total hip. And I'm happy to say that after 5 years of caring for her, she's had no further fractures. So just a closing the loop, if you will, on that particular patient. So just to conclude, I think treatment decisions that we make now really should be based both on overall fracture risks, or the 10-year numbers that we get from the FRAX algorithm, and consideration of imminent fracture risk over the next 1 to 2 years in that patient. I think the approach to high and very high risk patients is changing. I think we now appreciate that sequences of therapy matter a great deal, that you see faster responses and prolonged benefits in terms of counting fractures with a course of anabolic therapy. And I've tried to highlight some of the differences among the anabolics that we currently have and suggest that ideally we use them appropriately, we use them sequentially, and we follow that therapy by an anti-resorptive. And I think in the end, we will achieve the highest risk-benefit ratio for our patients. And with that, I'll stop and be happy to take your questions. Thank you very much for your kind attention and again for this wonderful opportunity to present to you today.
Many thanks for your talk, Dr. Schoback, and bringing your intense expertise in this area. I'm sure some more questions and posts will come through, but I'll just get us started. First off, a comment from our colleague, Dr. Dave Gilbert, noting Dr. Kammer hoped the lectureship would inform and inspire colleagues. Your presentation would make Cam very happy. So thank you.
Makes me feel very good.
And just a follow-up question. What is the expense of the new drugs, and are they covered by third-party insurers?
It's a very good question and a very important question, and that's why I think risk stratification is so important. And I think having these guidelines to back up decisions that we make are very helpful as well. So the costs. So teriparatide has become more expensive over time, in fact, but there is a generic version that's actually quite a bit cheaper. And I think we're talking about something in the range, and cheap is a relative term, of course, something in the range of probably about $1,800 or $2,000 a month. So pretty significant. Abaloparatide is, and these are California prices, so I don't know, maybe you're getting a better bargain in Oregon. Abaloparatide is probably in that $1,600 to $1,800 a month range, so not trivial. Romosozumab, I've had difficulty getting the exact number, but the cost of a year course of therapy is, I think, about $26,000. So your question is on point. These are expensive therapies, and why, I think the important thing to realize from looking at all the evidence that, these task forces looked at, really we do have multiple agents that can be deployed. I think for example, the patient that I presented to you, this is a working woman. This is someone with many years of life expectancy ahead of her who wants the best possible outcomes. I think those are situations where one would take on that extra expense.
Mm-hmm. Yeah, thank you for your comments. Always considerations for every individual patient.
Right.
Along those lines, you discussed the importance of sequence, and maybe have you flesh that out just a bit more, I think indicating a role for an anabolic therapy, preferably first, followed by anti-resorptive. And just to be clear, if, say, a patient has been on anti-resorptive therapy and perhaps failed, then is it okay to revisit an anabolic?
Absolutely. I think that what we know, I didn't show any of the trial data on this, but what we know is that there may be a bit of a delayed response if they've been on an bisphosphonate, for example, for a long time. You might see a bit of a delayed response to teriparatide, for example, or abaloparatide. But eventually, after 18 months of therapy, the patient should get to where the treatment naive patient might get. Now, treatment with denosumab, because it is so very potent and because of its unique mechanism of action, when you give an anabolic agent after that, I think particularly the data I'm thinking of are with teriparatide, one may not see as robust a response to teriparatide in that particular setting, because of the mechanism of action of denosumab to suppress osteoclast activity, but the cells seem to still be in the bone. And so there at the spine, things seem to be okay, but at the hip, bone density sometimes goes down during a round of therapy with teriparatide. So that sequence might not be the favored sequence. What we don't know is whether, for example, in that individual who's received denosumab, whether romosozumab might be a potential agent that would have a good effect because it does have both the dual action of stimulating formation and blocking resorption. But that is the one sequence, denosumab followed by teriparatide, which doesn't look like the best sequence to go after.
Great, thank you. The questions continue to flow in, so we'll just press forward. Many patients are started on denosumab due to renal insufficiency. After 5 to 10 years, what do you transition to if osteoporosis persists and renal function is no better?
Yes, it's this person hit the nail on the head. This is a question that comes up so often in our clinic. You really don't have a great option for transitioning because you can't, if renal insufficiency prevented you from starting a bisphosphonate, certainly it often doesn't get any better and allow you to get away from using a bisphosphonate. One might consider, if it's not severe renal insufficiency, half dose every other week. This is all completely off label. Most patients with chronic kidney disease aren't good candidates for drugs like raloxifene or estrogen, and many don't want to take them. They have high vascular risk. You end up most of the time continuing the denosumab or stopping it and paying the consequences. I have maybe once or twice used injectable calcitonin if it was really a high-risk situation. It's a very tough bind that you're in, and it is difficult. It's very difficult to use denosumab safely in chronic kidney disease patients because they have a pretty significant risk, depending on how advanced their chronic kidney disease, of having hypocalcemia as a side effect of therapies. Many times it's not clinically, it doesn't present as symptomatic hypocalcemia, but oftentimes the calcium will drop to levels of 7, low 8, 6, and you have to monitor them extra carefully. So it's a very treating patients with osteoporosis and chronic kidney disease is definitely a very special situation. Lots of challenges there.
Great, thank you. Thanks for your comments. Another question, you noted that the duration of teriparatide has now been extended such that you don't have to limit it to only 2 years. And might you comment on when you might extend it longer and whether you would have a wait time to determine a retreatment?
Right. I mean, this is a great question, and I hope somebody is going to do a study that will really inform us about the specifics that would be the right answer to that question. I don't extend it for 3 years typically, for example. The usual course I start with is 18 to 24 months because most of the benefits from the trials really occurred in the first 12 to 18 months. So what I will usually do is a course of probably 18 to 24 months of therapy, then consolidate, usually with a bisphosphonate. And then depending on how the patient does over time or if more fractures occur, then I would intervene. And I'd probably wait, 1 to 2 years. And it's not based on hard data, but it does take the cells in the bone to you need a population of stem cells or early osteoblasts to respond to teriparatide. And as patients get older and older, those cells are in short supply. So I like to wait at least 1 to 2 or 3 years or longer before I would give a second course. And what we can tell from the limited data we have on these second courses is that the amount of response is less. But if the patient tolerates it and it makes sense from the standpoint of potentially a fracture or helping to heal a fracture or something like that, I think it's a reasonable possibility, but I haven't used it repetitively a lot.
Great, thank you. Thanks for your expertise in these emerging areas. I'm going to pair a question regarding Alendronate. So first off, just a question about when you take a bisphosphonate holiday, how long should the holiday be? And then is the typical course of treatment, if resumed, again, 5 years? And then maybe just pairing that with any comments regarding concern for osteonecrosis of the jaw, which frequently emerges among our patients, and specifically whether oral therapy is better than IV, and whether the dental history matters. So a little potpourri of bisphosphonate common questions.
Lots of questions within there. And so I'll just say that with regard to the drug holiday, there's the information that's in the literature are very small studies on this. Usually I monitor bone density. Sometimes I'll monitor bone turnover markers in the higher risk patient. And then once bone density starts to fall or the turnover markers go up or a fracture occurs, retreatment, I initiate retreatment. It might be with the same agent. It might be with an anabolic agent, for example, if a fracture has occurred. The treatment course, boy, that is a difficult one because really I don't think we have any trial data where you do a drug holiday and then you restart therapy. But usually I would give it another 3 to 5 years looking at what happens to bone density during that and what happens to the patient clinically during that retreatment period. Now, one of the other questions you asked is related to the different bisphosphonates that we have, because we have 4 of them. Are there differences in the duration of the drug holiday with the different agents? And I would say I use mostly Alendronate and zoledronic acid in my practice. So my experience is the greatest with those 2. And I would say that they are probably the ones where you can have the longest drug holiday. And maybe that's 3, 4, maybe 5 years because they have they're more potent in terms of their adherence to bone, and the effects last longer. Residronate comes off the bone perhaps a little bit faster, and so the drug holiday might be more like 2 or 3 years with that agent, and similarly, potentially with the Bandronate. So that's how I would approach drug holiday in terms of the different bisphosphonates. Now, the question about osteonecrosis of the jaw specifically, the questioner is right. The duration of bisphosphonate therapy is tightly linked to the occurrence of it. And so dental history and dental health to me matters a great deal. I don't like to even start an oral bisphosphonate if the patient isn't under regular dental care. And if dental issues aren't addressed prior to the institution of therapy. So I believe a lot in really good dental care, and that's tough often, but yeah, nonetheless, that's the ideal I'm striving for. The second course of this, if a patient has serious dental issues and we're thinking, and they've been on a drug holiday, then I'm going to be thinking about, and I want to restart therapy, and then I'm going to think about an anabolic therapy. I'm going to think about something that the dentist is going to be happy that I've started in that patient. And hopefully it will help with dental bone, and hopefully it will help with other areas. But I agree with you. It is tough if there are serious dental issues, and there certainly can be in these patients, and managing both things. And we don't have a lot of data on numbers in terms of absolute risk of ONJ with second courses of therapy. I hope, new papers will come out, sort of observational studies on that. But most of the time, people refrain from using those therapies if there is a case of active osteonecrosis of the jaw in a patient with osteoporosis. In the limited experience I have with patients with cancer and osteonecrosis of the jaw, sometimes the oncologists decide to go on and continue therapy because of the metastatic lesions and so forth. So it's a very individualized patient preference and important discussion with the patient as well.
Great. Well, I want to be respectful of our time. We have passed 9 o'clock, so thanks so much for sharing your expertise, Dr. Shovak, and a real tribute to Dr. Kammer. Thank you.
Thank you so much for the invitation and your attention and just the wonderful questions. Much appreciated. Wish I could be there with you.
Yeah. Next time. Thanks, everyone. Welcome back.